So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all once again to our ACTREC Head and Neck Saturday academic classes. Our today's speaker is Dr. Natarajan Ramalingam. He is assistant professor in Department of Head Neck Surgery at CMC Vellore. He will be speaking on the surgical anatomy of maxilla. With this, I welcome Dr. Natarajan to please start with his lecture. Thank you, Dr. Natarajan.
Thank you, ma'am. Good morning, everybody. Thank you for this invite. I'll just share my screen. Is my screen visible?
Yes, Dr. Natarajan, it is visible.
Yeah. So I'll be speaking on the surgical anatomy of maxilla. And the contents of this talk will be on the lines of embryology, surgical anatomy with special emphasis on pterygocarpine fossa, interdental fossa, cerebral correlations. So coming to the embryology, it all starts by the end of fourth week, where the facial prominences, which are primarily derived from the neural crest derived mesenchyme, from the first pair of pharyngeal arcs, there are two prominences we need to focus on: the maxillary prominence and the mandibular prominences. These give rise to the future maxilla in the mandible and eventually harder. So by the end of 5 weeks, the maxillary prominence starts to go towards along with the mandibular prominences. When the nasal prominences migrate laterally, we continue to grow inwards. And as we see in the 7 weeks embryo, we start fusing with the proper nasal prominence and the maxillary prominence, forming the future nasolabial fold area along with the development of the nasal folds.
If you want to see this on the Tata Memorial, they're giving some lecture, anatomy of maxilla. If you want to see this, every
next development at around 10 weeks, you can see that the future maxilla has been formed almost completely, except for the persistent maxillofacial tube. Coming to the palatine process, there are two types of palatine development. There's a primary palate and also the secondary palate. The primary palate develops from the maxillary prominences, where they fuse by the end of 6 or 7 weeks, forming the primary palate. And secondary palate starts developing as an approaching from the palatine shells, which are also from the maxillary prominence. You can see the palatine shells migrating towards each other, with the tongue getting pushed down, and subsequently both of them join together. So why is insisting on this, showing this development is that pertaining to the facial maxillary cleft defects,
Dr. Natarajan, sorry for the interruption. I think the voice quality is a bit unclear.
Yeah. Is it okay now?
It is now better, Dr. Natarajan. I think a bit less it was initially. So
okay,
it can be a bit more or closer to the speaker. Yeah, thank you so much.
Okay. Sorry about that. So the why I wanted to insist on this embryology is that since the development proceeds unilaterally and there is fusion of both sides of maxilla, tumors pertaining to one side of maxilla can have theoretically bilateral metastasis and also posterior nodal metastasis towards the retropharyngeal nodus. So this is the embryological basis for that. Coming to surgical anatomy proper, maxilla have a pair of fused bones on each side, cancellous bones developed in the facial skeleton. So there are 4 surfaces: one facial surface, orbital surface, medially the nasal surface, and posterolaterally the infratemporal surface. And it has 4 processes.
Hello, sir. Sorry to interrupt.
Sorry.
I think the microphone quality is not. It's all broken. The voice is not clear.
Can you hear now?
Yeah, we can hear right like this, but yeah, in the flow it is breaking multiple times.
Rajan, okay. I think it is cracking in between. Yeah.
Is it fine now?
Sorry, but there is some disturbance, Natarajan.
Yes, ma'am. Somebody's mic is on. Now is it okay?
I think.
Yeah.
I think so. Yeah.
Medial 2/3 and lateral 1/3.
No, last point. What you said.
Subclavicular groove will be.
Yeah. Is it okay now? I'm sorry.
Yeah, it seems better, Dr. Natarajan, but I think there is some disturbance. I think, yeah. But it is looking better, a bit silent now. Yeah.
Okay, ma'am. So we have 4 processes. One is the alveolar process and the palatine process, which is not shown here, and frontal process and the zygomatic process. So these processes serve as buttresses in day-to-day activity. In case of malignancies, these are weakened by the cancer progression, or maybe after radiation, these are chances of getting weakened. So this can easily fracture, and this leads to tumor progression and spillage. So while doing surgery, for doing the bone cuts, exposure of all these buttresses are necessary so that the specimen is delivered without any avulsion and margins are not compromised. So coming to the facial surface, this surface is palpable through the gingival and labial surface. The infraorbital foramen, as you can see, opens between the orbits of 2 muscles, which are levator labii superioris and levator anguloris. And the infraorbital nerve supplies the skin over this surface and also the upper lip. Point to be noted is that anterior superior alveolar branch, which is a branch of the infraorbital nerve, is given before it exits through the foramen. So this specific nerve supplies the incisor peak and the anterior end of the meanders. So the clinical importance is that when patient has had a previous calvalar surgery, the numbness will be limited only to the incisors. But when the tumor, which is involving the floor of orbit without extension into GPS, patients may have a number of numbness of upper lip and incisor area because of the involvement of anterior alveolar. But when the tumor reaches the GPS, it is direct. With the direct involvement of the floor, can have numbness or paresthesias. Coming to the orbital surface, this surface is not horizontal. It has a slight slope and also posteriorly. So tumors which are present posteriorly and medially can have an early involvement of orbit due to apex involvement. So getting an adequate margin is difficult in these specific areas. The lymphatics of this from this surface drains through the infraorbital fissure to the pterygopalatine fossa and infraorbital fossa. So you can see if orbit is involved or the orbital floor is involved, you may have to think of clearing the IPF proper margins. So you can see that the canal is placed lateral with respect to the maxillary roof. So tumors of the medial part of the sinus can directly extend to the orbit without involving the orbital. Coming to the nasal surface, this is easily accessible for examination and also for tissue biopsy. The most important feature is the opening of the sinus. So this leads to early involvement of the nasal cavity and extension to the septum, maybe also to the contralateral side. And posterior inferiorly, the greater palatine canal opens. So for tumors involving this part can have hemipalatal anesthesia on the palatal side. And anterior superiorly, we have the nasolacrimal duct and the lacrimal sac, which is close relation to the maxillary medial wall. The involvement of pterygopalatine fossa can have palatal anesthesia, and with the involvement of secretomotor fibers to the lacrimal glands, there will be early presentation of dryness of eyes. So you can see that the symptomatology of the maxillary sinus carcinoma on the heart is closely related to its anatomy. So that's why I'm emphasizing on each and every point. Coming to the infratemporal surface, this has fine grooves posteriorly to transmit the posterior superior alveolar nerve from the pterygopalatine fossa. So involvement of this wall can have altered sensation on the molar, premolar teeth, and the posterior alveolus, especially on the buccal aspect. Involvement of greater palatine nerve will have paresthesias on the heart palate aspect. So tumors involving only this part can have a normal facial sensation, but with paresthesia of the posterior heart palate and the so the alveolar process has canine and incisive fossa, which people need to be aware of. So through this, tumor can extend anteriorly to involve the skin and subcutaneous tissue, and laterally we have a maxillary tuberosity, which is a projection in the posterior end. So sharp dissection is required in these areas because of attachment of multiple muscles. So you can see that the antral mucosa has close relation to the premolar and the molar teeth. So dental pain and loosening of teeth can be an early feature in when antral mucosal floor is involved. And the patient may present with pain when chewing, and also this may be the first complaint of the patient. when there is an intrasinus tumor which is starting to erode the floor. Coming to the palatine process, there is a thin shelf of bone forming the anterior two-thirds of the hard palate. It joins posteriorly to the horizontal portion of the palatine bone, forming the entire hard palate. So the antrum may pneumatize to this process. So when in this situation, tumors can easily involve the hard palate early. So that is why in AJCC staging, if you see patient, cancers of the maxillary sinus proper, which is involving hard palate, are staged as T2, whereas cancers of oral cavity or hard palate, which is extending to the sinus, are staged as T4. So that's the difference. Because of early involvement of hard palate is possible when sinus tumor is present, they are staged early because of the close anatomical proximity. And secondly, one more point which I want to emphasize is that you can see palatine glands, which are mucosa secreting glands, are present deep to the mucosa along the entire length except for the anterior part. So this form, this gives a characteristic pitted appearance, orange kind of appearance. So the take-home message is that this glands can, from these glands, the patients can have minor salivary gland tumors which are concentrated posteriorly, which are seen rare anteriorly. So these tumors are seen posteriorly because of this anatomical entity. And next is, I've emphasized already, this picture shows the greater palatine nerves and lesser palatine nerves extending from the pterygopalatine ganglion to the greater palatine foramen anteriorly and posteriorly. So involvement of this specific area causes anesthesia of the entire heart. And also the second point which is to be noted is that the greater palatine artery also exists through this. So this artery can be the pedicle for the palatal flap, which can be raised along this entirety for closure of buccal mucosal defects and other oral cavity defects. The last process is that frontal process. It has three surfaces: facial, lacrimal, and nasal. The main important anatomical correlate of this process is that this resection of the frontal process is essential to have a good access to ethmoids because ethmoidal malignancies have close correlation coexistence with the maxillary tumors. And this also, a restriction of this also is required for proper exposure of therapy from palate and diagnosis in craniofacial sections. Zygomatic process is the latermost process. So the cancers which are present in this area, they look worse, but they respond best because of early facial deformity. Patients will reach the doctor early. So since it is very far from the skull, surgery is very helpful. Coming to the next important activity, maxilla is the pterygopalatine fossa. This is not really proper maxillary related to proper maxillary bone, but it is in close relation with functioning. As you can see, the borders
Dr. Natarajan, Dr.
Yes, ma'am. Yes, ma'am. Hello.
Natarajan, sorry to interrupt. I think the voice quality is a bit inaudible because this is cracking a lot in between. Sorry for the interruption. Hello.
1 second.
Can we do something about it?
1 second. I'll see.
Yeah.
Is it okay, ma'am, now?
Right now it seems okay, Dr. Natarajan. Earlier also it was okay, but I think while taking the lecture, somehow it is cracking a lot. And we are not able to hear all the words properly. Like it is cracking and then in between some words are not audible properly.
1 second. Just, try to log in from another device.
Yeah, I think you can try that. We can wait and you can do that.
Ma'am, is the audio okay now?
Yeah, it seems okay, but there is some echoing. I think there are two devices, I think, so I think there is some echoing. But
How is it
other
now,
than
ma'am?
that, it is looking better, I think, right now.
I'll share my screen, ma'am. One second.
Yeah.
मैम मेरे को मिल गया
All others, everyone, please keep yourself muted. Yes, Natarajan, we can see that. Yeah.
Yes, ma'am. Okay. So coming to pterygopalatine fossa, the importance of this is that, is the audio okay, ma'am, now?
Yeah, it seems very good now. Yeah.
Okay, ma'am, fine. Okay. So this pterygopalatine fossa is not a proper anatomical entity pertaining to maxilla, but it is closely related functionally, and it's worth looking at it with respect to anatomy of maxilla. This is a small pyramidal shape area which is located posterior to the maxilla, which is formed and bounded superiorly by the inferior orbital fissure and the infratemporal surface of the greater wing of sphenoid. Laterally, it is communicating to the infratemporal fossa through the pterygomaxillary fissure. Medially, it is abutted by the perpendicular plate of palatine bone, and posteriorly, pterygoid process of the sphenoid is the posterior wall. Floor is the pyramidal process of the palatine bone, and anteriorly, it is the posterior aspect of maxilla. So this will tell us that since maxillary tumors can have an early neurovascular involvement, so knowing this, pterygopalatine fossa anatomy is important for complete R0 resection. This pterygopalatine fossa has communications towards through multiple foramina. Specifically speaking, medially it opens through the sphenopalatine foramen into the nasal cavity, and anteroinferiorly through the greater palatine foramen into the palatine canal into the heart palate, and anterior superiorly through the foramen rotundum, pterygoid canal, and a palatovagal canal, where maxillary P2 segment nerve to pterygoid canal and the pharyngeal nerve and artery enter the pterygopalatine fossa, and superiorly through the infraorbital fissure it communicates to the orbit. And also you can see the vascular communications also. So why this has to be noted is that involvement of pterygopalatine fossa can have all the neurovascular disturbances which I've elucidated before. So involvement of this, patients who present or OPD with early paresthesia or anesthesia, we may have to think of doing an MRI along with a CT scan for a proper neurovascular assessment, because MRI will help us to have a good assessment of the perineural spread rather than a CT. Coming to the infratemporal fossa, this pterygopalatine fossa communicates laterally to the infratemporal fossa. This fossa is formed superiorly by the greater wing of sphenoid, foramen ovale, and spinosum, and laterally by the coronoid process and ramus of mandible, and inferiorly by the alveolar process of maxilla, and continues inferiorly as the parapharyngeal space. Anteriorly, it's formed by the posterior surface of maxilla. The lowest portion is formed by the maxillary tuberosity. Mid portion has small foramina, which I've told earlier, where the posterior superior alveolar nerve enters, and the posterior wall of maxilla and greater wing of sphenoid meet at right angle superiorly at the infraorbital fissure. So involvement of tumors with the posterior wall will preclude the excision clearance of infratemporal fossa for proper R0 clearance. The posterior wall of the ITF is formed by the spine of sphenoid and the auricular tubercle of temporalis. Medial wall is formed by the lateral pterygoid plate and associated muscles and pyramidal process of palatine bone. The lymphatic drainage is different. The respiratory part of the nasal cavity, where it means the medial wall, the nodal drainage is along the anterior jugular chain and the IJV. The maxillary and ethmoid sinuses drain into the retropharyngeal nodes. From the lateral part of the maxillary sinus, the drainage is to the submandibular and upper deep cervical nodes. So the invasion of oral cavity carcinoma by the antral carcinoma has a different nodal pattern, where the nodal pattern of metastasis is like a oral cavity tumor. And also worth mentioning is that there is no lymphatic connection between the antrum, buccal mucosa, or the orbit. This connection happens only by direct extension. So when tumors involving extends directly to the buccal mucosa, the nodal pattern will be altered. There is more chance of occult metastasis because of drainage into the retropharyngeal node. So it's important to look at the MRI or the CT for specifically for the for the retropharyngeal nodes for planning of surgery, because clearance may not be possible if retropharyngeal nodes are involved significantly. I'll be doing a short clinical correlation pertaining to anatomy. So the clinical presentation of CA maxilla depends on the spread of the tumor. Primary carcinoma of maxilla usually presents as sinus with pain and discharge. The symptoms points towards the carcinoma occurs after the local spread. So we have Robin's clinical phases, which was described first before. It has 4 phases. Phase 1 masquerades as sinusitis. Phase 2 has dull aching pain with subtle changes in symmetry in X-ray. Phase 3 has nerve infiltration leading to pain, which is out of proportion to the signs. Phase 4 has gross local findings. The classic triad of facial symmetry, asymmetry, and tumor bulge in oral cavity and tumor in the nasal cavity is present only in 40% of the patients, with 90% of the patients having at least one of the 3. Oral symptoms, it's due to direct downward extension. Patients may have dental pulp type pain, posterior superior alveolar nerve involvement, ulceration as you can see in the picture, oroantral fistula after loosening of teeth and extraction, malocclusion, loosening of ill-fitting dentures, palatal bulge, and palatal anesthesia. When tumor extends to the medial wall, patient can present with nasal obstruction, watery purulent nasal discharge with epistaxis, pain, and also a nasal mass and examination, so which can be biopsied. Superior extension causes ocular symptoms with fullness of infraorbital region with anesthesia, blunting of infraorbital margin, non-axial proptosis, diplopia, vision loss, and restricted eye movements, and fullness of lower eyelid and epiphora when the involvement of lacrimal sac and nasolacrimal duct. So ocular symptoms are morely seen in ethmoidal tumors, but majority of the maxillary tumors have extension to the ethmoid air cells also. So there are 3 phases of orbital invasion. One is only the medial wall is eroded, and secondly the periorbital fat is involved, and thirdly the intraconal part, which is involving the medial rectus, optic nerve, ocular bulb, and eyelid skin. Coming to the anterior extension, patients can have a cheek swelling, fullness in the nasolabial fold, lifting up of hala of nose, numbness and paresthesia of face, swelling in the malar area and temporal region superiorly, skin ulceration, widening of nasal dorsum when tumor involves medially, and widened intercanthal distance when there is ethmoidal extension. Very advanced tumors present with neurological symptoms like anosmia, headache, pain and numbness on the mid-third of face, 7th cranial palsy, and deafness. So tumors of the postero-superior wall have a dismal prognosis because of several reasons. One is that early access to lymphatics and regional spread through the maxillary ostia. They tend to present late because of posterior extension, because it is too deep to cause a deformity in face, and it's too high to cause dental issues, and it's too medial to cause V2 nerve involvement. So all these have make the patient symptomatic early. So tumors in these parts have very late presentation because of all these features. So I'll touch upon 2 historical classification systems which are not in use now because of the advances in treatment and advances in diagnosis. One is the Letterman and Sitler's classification, where the maxilla is divided into 3 areas: infrastructure, mesostructure, and infrastructure. So tumors involving the infrastructure have good prognosis because of early presentation than the suprastructure and posterior extension tumors. The other classification system which was in use before was the Ongren's system of classification, where it's an imaginary plane drawn between the medial canthus and the angle of mandible. Suprastructure tumors have poor prognosis, whereas the infrastructural tumors had better prognosis. So, but now AJCC's classification is the gold standard, where you can see T1 tumors are limited to the maxillary sinus mucosa without bone extension. T2 tumors have extension to the hard palate, as I had mentioned earlier, with medial extension to the nasal meatus, except posterior extension. T3 tumors have anterior extension and the posterior extension and involvement of pterygoid fossa and ethmoid sinuses. And T4E and 4B have bone erosion, pterygoid plate involvement, ITF extension, and intracranial extension. You can see that the prognosis also varies according to the T stages, with better prognosis for early stages and dismal prognosis for late stages, with survival rates accordingly. Thank you. I'm sorry for the problems in the audio. Any
I think
questions and comments?
there are some issues, but it is okay. Thank you, Dr. Natarajan, for a wonderful
ma'am.
lecture.
Thank you.
Anyone has any questions, please put them on chat box. So meanwhile, Dr. Natarajan, I think we have already explained all the important points. What would you suggest? What will be the most important this clinical features in a carcinoma maxilla? Because one point we usually discuss is that usually the lesion which is seen on the palate can sometimes be the tip of the iceberg.
Yes, ma'am.
So would you like to elaborate on that, Dr. Natarajan?
Yes, ma'am. Since maxilla is a three-dimensional structure with it has almost like a four-walled structure, the tumor can originate in any place, and extension is the only one thing which we can see. So, as Madam mentioned, when there is early hot palate involvement, that doesn't mean that the other walls of the maxilla are not involved. And also, there is high chance of neural involvement because of the close proximity of the pterygopalatine fossa and the ITF region. So, patients can turn inoperable or unresectable in a matter of weeks unless early examination is done and early investigation and planning is done.
Yes, and and I think the important point which I am saying here is that we should know that even a small lesion which is on the palate can be going along, which Dr. Natarajan rightly said. One thing I would request that all the attendees should keep themselves muted, please, because we are doing a class for all of you. Please, when you join, please keep yourself muted. So I think one important point which we have to make it here is that these lesions, even they may be small on the palate, you always have to do a CT scan. Even if you are very confident, then you can do just a palatectomy. We would advise that please do a CT imaging so as to rule out the involvement of the lesion involving the pterygopalatine canal and then going to the pterygopalatine fossa. If there are any questions, please put them on chat box. And I would request all of you to please, whenever you join or after joining, please keep yourself muted. So, if there are no more questions, Dr. Natarajan, Dr.
Yes,
Natarajan, you are
yes,
muted. So anything else? So there is one question that if pterygoid plate is involved, should we consider it resectable for CA maxilla? We are talking here.
Yes, ma'am. So pterygoid plate involvement, actually it depends on which part of the pterygoid plate is involved. Usually the inferior part may be considered resectable. The superior part may have early extension to the plexus above that internal carotid artery plexus are also to the orbit apex to superiorly. So that can be the cutoff. I don't think there is any specific guideline which can say that this part of pterygoid plate is unresectable or anything.
Yeah, I agree with you, Dr. Natarajan. I think like you rightly said, if the inferior part of the plate, which is more or less free, we can remove it and we can probably get a margin. Moreover, in CA maxilla, it is pterygoid plate involvement, I think, is considered as T4A. That's why the question is there. But in fact, you have to understand that if the lesion is going higher, closer to the pterygoid fossa, you will not be able to achieve a free margin. So that point has to be considered while deciding for resection along with the pterygoid plates if it is eroded. So, Dr. Natarajan, any excess osteotomy related to anatomy? Any significance of that?
Ma'am, yes. When there is usually patients have anterior extension and zygomatic extension, process extension. that usually the cut may not be needed at the buttress. It may have to progress laterally, and also when there is superior extension, we need to go till the fissure area for a proper in the orbit for a proper resection. So it depends on the local extent and clinical finding. We need to alter our osteotomy. Otherwise, the osteotomy are standard as given in textbook.
Correct. How to prevent trismus post maxillectomy? Any like suggestions from any tips from your side?
Yes, ma'am. One thing is that the coronoid resection has to be done along with maxillectomy for proper margins, and secondly that temporalis muscles are cut so that the mouth opening is a little bit better, and also as always tissue replacement for like in form of free flap will help in long run with good mouth opening rather than a obturator insertion or a pedicle flap. Free tissue transfer will have a good cosmetic outcome and also good functional outcome.
Right. There's one more question. Do you suggest imaging in all trigeminal neuralgia, TRO, infratemporal or pterygopalatine pathology?
Yes, ma'am. For this specifically, patients with recalcitrant, who do not respond to medical management, it is wise to have an imaging to rule out any other local causes which causes the malignancy, because tumors in this part or maybe benign tumors also like a schwannoma or something can have such a presentation. So I would suggest an imaging when patients do not respond to standard medical management.
Correct. So I think there is a similar question. Should we attempt to operate if the pterygoid is involved? I think pterygoid plates again, or should we
Yes,
deny it and explain to the patient?
Yes, ma'am. Depends on the location. High up pterygoid involvement will not be operating because of will not be able to have a good margin, clear margin resection. So that's
But like you rightly said, objectively there is no such criteria.
yes, ma'am.
Like
Yeah.
where this high pterygoid plate involvement is and where is low. So if you say by like our assessment on CT scan, again we would say that the lower part of the plates
Yes, ma'am.
where it is not reaching till the pterygoid fossa, I think still you can attempt it, but you will have to do a proper ITF clearance with removal of the whole of the pterygoid plates, because that is the only option you may have. And these patients many a times may not be good responders to other mode of treatment. But if the disease is grossly involving the pterygopalatine, involving the pterygoid fossa, we are not talking about the pterygopalatine fossa. We are talking about the space between the pterygoid plates. So if it is reaching higher there, then it is advised that you can tell the patient that it is inoperable and you will not be able to achieve good margins with that. And you can look for an alternative treatment with suboptimal response. So that would be the way to go.
Yes.
So I think there's one more question, Dr. Natarajan. What is the ideal and different ways of reconstructing the orbital floor post total maxillectomy?
Ma'am, the ideal way would be a bone tissue transfer, one to have a good cosmetic outcome on the anterior face and also to buttress the orbit. But other methods of reconstruction would be one to have a sling, maybe a mesh repair or a facial lata repair. So that may be suboptimal, but in the absence of free flap tissue transfer, that will be a better option rather than without doing anything.
Yeah, I think, but the best way would be to reconstruct it with the bone.
Yes,
because
ma'am.
otherwise the eye is going to fall subsequently and there is going to be diplopia, which is actually a very bad feeling. Patient will have vertigo, will be uncomfortable, will be unsteady gait. So it is always advisable whenever you are removing the floor of the orbit, unless it is contraindicated, please reconstruct it with something bony, which ideal would be a fibula or sometimes different kind of bony flaps, which are free flaps. But like Dr. Natarajan rightly said, if you don't have facility available, you can use slings. But the best way to go ahead with will be with bone only. Dr. Natarajan, two more questions again.
Yes, ma'am. Yes,
Sir,
ma'am.
while taking temporalis flap for recon, how can we make, how we take it, I mean, respecting ramus for space to take the Can you read what you
Yes,
recommend?
ma'am. Yes, ma'am. I think they want to know that how to deliver the temporalis muscle into the oral cavity, because there is after a maxillectomy, the space is there. But what happens usually is that when you resect the ramus of mandible, you may end up injuring the main vascular supply, because the main supply of deep temporal artery is just deep to the coronoid process. So while doing a maxillectomy, you should take care of, while resecting coronoid process, if a temporalis flap is being planned. Usually the temporalis muscle is tunneled superiorly under the zygoma when there is an intact zygoma, when there is an inferior partial maxillectomy which is being done. It doesn't preclude movement when there is a total maxillectomy defect. But when there is a partial maxillectomy defect, zygoma has to be undermined subperiosteally and the muscle has to be delivered safely. The main point is that ramus resection may endanger the vascularity of the temporalis flap.
Any role of neoadjuvant chemotherapy in these unresectable cases like involvement of tibial-palatine fossa?
Ma'am, I don't think there is evidence. There are some trials which are DECIDE trial and paradigm trial, which they have looked at. The goal was looking at N3B disease, but they have even the tax population, tax 324, 323 population also had some maxillary sinus tumors, but there is no like evidence generating results saying that NACT may be helpful in these unresectable cases. They can
And
be
moreover-
used to bioselect patients for CTRT. Maybe that's the maximum thing which we can understand.
And moreover, I think none of these trials describe the exact extent of disease. If these
Yes.
patients really had pterygoid fossa involvement or unresectable disease, because many a times we know that their description may not be, they may just have written that T4A, T4B advanced disease, but they may not be describing it in detail. So we don't have enough data to suggest or to say it may be useful or it may not be useful. So I think that is open to debate. That the role of NACT, we really don't know if there will
Yes,
that will be helpful for pterygopalatine fossa. If you have no other option, patient is fit, yeah, the medical oncologist is ready for that, you can give a trial of neoadjuvant chemotherapy. But you have to understand that there will be side effects to chemotherapy as well. So please take that into account and go ahead with that. For reconstruction of orbital floor, can we use orbital plate, and how and where do we fix it?
I've not come across this. Sorry, I'll maybe look it up and share it. I don't think orbital plate is being planned. I don't know. I'm not aware of it, ma'am.
I think total maxillectomy means, when we are talking of maxillectomy, even though we understand can be of different types, but here particularly we are talking about the total maxillectomy, when we have removed even the orbital floor. So in that case, naturally, how can we use the orbital plate? I think there is some contradiction in this question.
I think they may be asking about recon plates, ma'am. I'm not sure of it.
But recon,
I've not come across anywhere recon plates being used. I'll look it up, ma'am, and I'll share it.
Yeah, but
maybe in the mail trailing mail. Yeah.
They are subject to exposure on radiation. So like we said, the best way to reconstruct is going to be a free flap, where there is a good vascularized flap is there to cover that area. So how to plan whether patient will require medial maxillectomy, endoscopic or open, or partial maxillectomy for disease clearance? We will be having a class on this subsequently. But would you like to answer, Natarajan? We are going to have another class on this.
Ma'am, it depends on the extent only, ma'am. Based on CT scan and endoscopic findings, and also the histology. If it's a minor salivary gland tumor which is extending only medially into the nasal cavity involving the medial wall, then maybe the patient can be amenable for a endoscopic medial maxillectomy. But in a squamous histology with extension laterally, posteriorly, superiorly, I don't think endoscopic excision will be possible for a proper clearance.
Correct. A temporalis flap can be used for anterior defect and posterior defect as well.
The problem with using temporalis flap anteriorly, ma'am, the facial asymmetry will be apparent, very apparent when we use only a muscle flap. So that is the problem. If cosmetically, there'll be a very poor outcome when you use a temporalis flap for anterior defect. For posterior defect, since it's just kind of an obturation, it's very good.
I think there is one last question that when should be, I think there are a lot of questions on reconstruction, which again
Reconstruction,
which
yeah.
we'll be having on in one of the classes subsequently. But last question is, when should we use obturator or when should we use flaps, like for different surgical defects of maxilla?
The basic idea is that obturator only will give a horizontal defect closure, not the vertical height. So when a vertical defect is also present along with a horizontal defect, we can, as per the James Brown classification, then a flap is required. But when there is no vertical height involvement, only a horizontal oronasal or oroantal communication is present, then an obturator is a reasonable choice. But some caveats are there. The obturator fitting should be adjusted. The status of contralateral teeth where the obturator is supposed to hang has to be taken into account. And rather than an obturator, a zygomatic processes with the implants is a better option when flap is not being planned. But cost factor is an issue.
Okay. So I think there are a lot of questions, Dr. Natarajan. Even
Yes,
again,
ma'am.
one more question. I think this will be the last we'll take. What holds the orbit from falling inferiorly, ligament or bone?
I'd say both, ma'am. Both the suspensory ligament of Lockwood and also the orbital plate will have prevents the orbit from falling down in the normal anatomical position.
Correct. So with this, we conclude today's lecture. And I thank you, Dr. Natarajan, once again for a wonderful lecture.
Thank you, ma'am. Thank you for the chance for presenting, ma'am. Thank you.
Thank you.
ଜଣେ ଆଉ 5 ମିନିଟରେ 2 ଜଣ ଆଉ ତାପରେ ଦିଦି ଆମ 3 ଜଣଙ୍କର ଛୁଟିରେ ହିଁ ପଡିଛି ଭାଇ ମୁଁ ଭାଇ ଆଜି ଆସିଲେ ବୈଷ୍ଣବୀର ମୁଁ କରୁଛି କାଲି ମୋର ହଁ କିଛି ତ ନାହିଁ କାମ ଅଛି ଆଉ